Okay, hello everyone. Good morning and welcome to the IDPH IPLAN training webinar series. Our third session in the series today, integrating health and racial equity into the IPLAN process. This webinar is offered through the end of 2024. This webinar series is offered through the end of 2024 by the Illinois Public Health Institute, me and my team, through funding from the Illinois Department of Public Health to support the Illinois Project for Local Assessment of Needs, or IPLAN. We are so glad to have you join us here today. We have some quick introductory things we'll get through, and then we'll go right into the content. Next slide. Our training team today from IPHI will be joined soon by Lori Call, our center director from the Center for Community Capacity Development here at IPHI, myself, Samantha Lasky, the program manager, and we'll have a peer presenter today, Leah Barth, the senior program manager with the Alliance for Health Equity at the Illinois Public Health Institute as well, who will join to talk a little bit about what we're doing here today. Next slide. We want to do a quick virtual introduction to just get everybody here participating, joining. So we're going to launch a quick poll that you should see pop up on your screen now. And the poll today, we want to ask how you incorporate health and or racial equity practices into your current IPLAN process. And this is an anonymous poll. We're not asking you for a name in this poll, so feel free to be as honest as possible. Looks like we're about 43% participating, so we'll give another minute. And if you just joined us, we're starting with an introductory poll that should pop up on your screen to see where we're at with how you're incorporating health and racial equity practices into your IPLAN process. Okay, so looks like mostly everyone participated. I'm going to go ahead and pause the poll here. So it looks like a majority of folks who responded noted that, yes, the IPLAN process, it currently has some elements of equity practices, but could use further improvement. About 58% of you, followed by 22% saying yes, it's fully incorporated throughout all stages of the process. And then 14% noted that you do not know if the IPLAN process considers equity. So thank you so much for sharing your responses to that poll. We'll move on. And we've got a box on the screen. Perfect. Oh, wonderful. So today's agenda, we sent out the agenda earlier this morning, and we're going to be going over some of these key concepts, and I'll go into that with the learning objectives today, but we will be reserving about 15-20 minutes at the end of the training today for the training needs assessment. We really want to get your input on what your training needs are as local health department members for the next year. So if you could hang on to the end of the training so we can hear your feedback, we'd really love that to help us inform what topics we talk about, how we are holding the training series for next year.
And it will save you time from having to take another survey later. So thank you.
Excellent. So our learning objectives today, we're hoping to explore how the role of personal power and privilege impacts the IPLAN process. We're going to identify at least 2 power practices to integrate into the IPLAN process. We're hoping that you'll be able to leave here being able to define structural racism and its relationship to public health, and to be able to identify strategies to create a more equitable systems. Our group agreements, if you've joined us before at our last 2 sessions, plus our TA sessions, those have stayed the same. We want folks to actively participate. We'll be having some breakout groups today, some polls, some chats. We really want to have this be an interactive session. We want to hear from you all. Make sure if you're somebody who takes a lot of space, talks a lot, oftentimes to give space to those folks who maybe we don't hear from as much. And if you're somebody who doesn't speak as much, who usually doesn't speak up, feel free to take some more space. We ask that you seek to understand different perspectives. We want this to be a great discussion, hearing from different perspectives from different folks from all over the place. We ask that you also allow us to move the conversation along. We want to make sure we get through everything, but we're having really good intentional conversations. So if the facilitator needs to move the conversation along, let's do that. We ask that you ask questions in the chat or raise your hand. We want to note that we are not experts, the end all be all experts. We don't know every single thing that there is to know. So if there are questions that we cannot address right then in the moment, we will make sure to note them and we will get back to you. You can drop at any point throughout this training in the chat questions. There's also a Q&A area at the bottom of your panel that says Q&A that you can drop questions in there. And feel free, if you're somebody who sees a question and you have some input on that, feel free to respond to that. We also will note that we will have a parking lot that we can park items that we cannot address today, so we make sure we get through everything, and we'll get back to everybody on those questions. I think that's all of our group agreements for today, and I'm not seeing anything in the chat. So we can move on to the next slide. Wonderful. And I will pass it back to Lori. Oh, I think you're still muted, Lori.
Thanks. We have a lot of people still joining, so if you can take over admitting people from the waiting room, that'd be great. Well, welcome everyone, and thank you for being here. We're really pleased to be offering this training, and hopefully this will for some of you be a nice introduction. For others, it might be reinforcing things that you already introduced or already know, and hopefully whetting your appetite to dig in even more, because we're barely scratching the surface here. So let's see if I can figure out how to advance the slides. I was doing so well. Okay, there we go. What I want to just reflect on is that as we're starting this training, think about what we practice at a small scale can really reverberate to the largest scale. So I tend to think of this as starting with yourself, starting with where your locus of control, where you have your sphere of influence, where you have some influence, but practicing a lot of the techniques and I guess power practices, different activities, different methods, things that we're talking about today, thinking about how it starts with yourself and how you can integrate it into existing meetings, into things that you do that then can be expanded out larger. And a lot of times we think about, oh, the community that I'm in or the community I work with, this isn't going to go over, this isn't going to work. If you start with yourself and you start with the way that you lead meetings and teams and those sorts of things, and then think about that expanding out, I think you'll see that it becomes a lot more. You have a lot better idea of how that can be spread and have success. The other thing that I wanted to say to sort of frame today's training is that health equity is so important, and we are at such a phase in our public health system that we have. One of the things that was done in the last couple of years was the state health improvement plan the law regarding that Illinois has to do a state health assessment and a state health improvement plan, just like local health departments have to do an IPLAN, that there were revisions to that law to intentionally integrate equity as an approach, even more so than it had been before. And in addition to that, while the state of Illinois' partnership for Healthy Illinois 2028, which is a state health assessment, and State Health Improvement Plan, as they looked at the priorities for the state and looked at all the data, just like you look at your IPLAN data, they decided to elevate racism as a public health crisis, that's a really underlying root cause, that systemic racism permeates all of the health issues. And if we don't address that, then we aren't going to be able to make any strides in any of the health problems or health areas. So in case you weren't aware of that, I just wanted to note that that has been elevated to a priority for the state of Illinois through the state health assessment. And SHIP implementation has been underway and is really launching heavily, beginning really now and through February. There'll be action teams formed and all sorts of things. So stay tuned for that. We'll update you in the iPlan trainings as there's information to share. But I did want to elevate that, and then also say that the other, social and structural determinants of health that really impact and are underlying root causes as well, that those are also cross-cutting priorities. So you may not see them as the health condition or the health problem that are on the outside of that circle, which are the priorities, but you see them listed as one of the cross-cutting priorities, meaning that they emerge in all five of those high-level priorities. So I wanted to share that. And then the next thing is that this is Chicago Department of Public Health's definition that they use as equity is both a process and an outcome. And we really like this and use this at the Illinois Public Health Institute as well, and want to reinforce that when we're talking about equity, we're talking about equity both as a process and the way that we do the work, but also as an outcome. So as an outcome, equity results in fair and just access to opportunity and resources that provide everyone the ability to thrive. And as a process, it really presents us with a way of doing things differently. So it prioritizes access and opportunities for groups that have the greatest need and may not always have that opportunity to participate or to provide input or solutions or even be part of those solutions. It helps evaluate benefits and burdens produced by what seems to be neutral systems and practices. And we know those are not neutral, even though they're potentially intended to be. And it engages those who are most impacted by inequities as experts of their own lives and their own experiences. So that's what we mean by equity as both a process and an outcome. And today, the practices that we're talking about, while they apply to race equity, they apply to a variety of different um, uh, uh, equity in general, I would say. And Leah Barth is going to talk to us a little bit about how she has ensured that this as a process, equity as a process, is integrated into the community health needs assessment work that she is part of. So we're excited to have her share. Okay. So when we think about all the systems that operate, everything, is a system. There are so many different systems. We want to really think about who has the power to decide how these systems operate and who benefits from these systems, and then who is most harmed by these systems. And so when you think about all of these different systems and we really stop to think about who's benefiting from them and who is most harmed, it really does give us some idea of whose voices often aren't involved and aren't heard as part of this process in this system. So we want to be thinking about that as we go throughout the training today. And I know that there are tools out there, whose voices do we want to hear from? Whose voices do we need to hear from? Who has the power? Those are some tools in the mobilizing action through planning and partnerships model that we will mention and provide resources to as we go throughout the training. And popping up, somebody's in the waiting room. So it's also important to be thinking through this lens of the different levels in which racism exists. So we know that there's internalized racism, um, race-based beliefs and feelings within individuals. There's interpersonal racism, between biases and bigotry between individuals through words and actions, institutional racism, discriminatory policies and practices within organizations and institutions, and then systemic racism, ongoing racial inequalities maintained by society. And we're going to see a little video today. It's a 4-minute video that will talk a little bit about institutional and systemic racism. And we're sort of starting out the day by thinking about internalized and some interpersonal racism, because it really does start with us as individuals. And when we're thinking about racism, we want to think about these different levels and the fact that people have to deal with these different levels all day, every day, and cannot escape this. So we sent out these definitions today just as a reference, and because we won't spend time going into all of these definitions, but they are important to keep in mind. We've already reviewed the health equity definition, and I just invite you to take a look at the racism and anti-racism definitions. We looked a bit at racism in the levels of racism. I'm going to look at the anti-racism one now, as the active process of identifying and eliminating racism by changing systems, organizational structures, policies and practices and attitudes so that power is redistributed and shared equitably. And I share that definition because you'll see in this training, we focus on some of those pieces. We focus on changing systems and what you need to do to change systems. And we focus on the power redistribution and building power. So I just wanted to put that into context as we're thinking about the definitions. And when you look at the definition here for power, the ability to define, set, or change situations. Power can manifest as personal or collective self-determination. Power is the ability to influence others to believe or adopt values as those in power desire. So, influence plays a lot of role into power as well. And then I think that we're going to be doing an activity that's really going to talk about intersectionality. So if you'll take a look at that one, it's really that framework that helps us understand different social categories that we can identify with, and reflects multiple interlocking and compounding systems of privilege and oppression at all of those levels because of those different categories that we may identify with. So someone really may be compounding all of that oppression based on different identities that they have. And we're going to do, like I said, an activity on that. Okay, and I will call out the definition here on privilege really quick too, because I think a lot of times people get very offended. Some people get offended by that term, and really it is advantages, it's systemic race-based advantages and preferred treatment based on skin color that leads to inequitable access to resources, opportunities, and rewards for non-dominant groups. So I want to just think about that we benefit from privilege. And if we think about it like that, it's not saying that anyone when we're talking about this today, we're not saying anyone here is doing anything wrong or has done anything wrong to have privilege. We were born into that privilege based on the color of our skin, and many of us have benefited from that. So that's really all we're trying to say here. Okay, so with that terminology, then I am going to turn it back to Samantha to talk about centering health equity.
Thanks, Lori. So as we know, since, for several years now, public health has been evolving to take a more active role in advancing health equity or the assurance of the conditions for the best health of all people. These definitions, like the one I just read here from Dr. Kamara Jones, And the definition of health inequities are definitions that we really like when grounding ourselves in this work. We recognize that despite our recent efforts, many people and communities do not have the opportunity to achieve health, and the differences in these opportunities are what we call health inequities. So the preventable differences in the distribution of disease and death that are systemic, patterned, unjust, and associated with imbalances in power and systems of oppression. So we really wanted to ground ourselves in these definitions as well as the ones that Lori just ran through. Next slide. As well as grounding ourselves in definitions, we think it's important to familiarize yourself with some frameworks that we utilize as we're doing health equity work. So there are two frameworks, this one and then the next one on the next slide that I'll be going through that our team oftentimes refers back to and references. In our work, we recognize that to achieve true health equity, communities must address the underlying systems of power, privilege, and oppressions that drive the inequities, which are the root causes of health inequity. So this first framework is the Bar High Health Equity Framework. Might be familiar for some of you, might not be familiar for us. For others, but this framework really recognizes that to move from downstream issues to upstream issues, we need to recognize that social inequities such as racism are often the root cause of disparate health outcomes that we're assessing when we assess risk behaviors, injury, disease, and mortality, those downstream issues, and that practicing authentic community engagement can transform the way that we think about health problems and helps us build a shared analysis of the problems to move upstream, to focus more on social inequities, institutional inequities, and recognizing that racism is often the root cause of these health outcomes. Next slide. Another framework that we often reference when we're doing this work, this is actually a framework from MAP 2.0. So some of you might be familiar with this if you participated in previous MAP 2.0 trainings or started to dig into that work, or if you participated in our September MAP 2.0 overview session. So this spectrum is called the Health Equity Action Spectrum, which is a from the power primer in this work. So on the health equity action spectrum, these items are listed on the left, such as the effects of racism, capitalism, and white supremacy, and recognizing that these individual issues, these individual behaviors, then are connected to social determinants and the root causes of issues. So this MAP 2.0 is designed with these tools and talking points, and there are also activities that can help begin the conversations with community to help build community health improvement plans that create lasting impact and keep health equity in mind. So the Power Primer, which we'll be going over some pieces of that throughout this training, and the power practices are included in the MAP 2.0 framework that really help us understand how and why to address power dynamics throughout the IPLAN process, acknowledge societal power imbalances as a root cause of health inequities, and build community power throughout the IPLAN process. So these are both frameworks that we've used in the past that we often reference back. We also recognize that it's important for health departments to find frameworks that work best for them, that relate best to the work that they're doing for their IPLANs. Next slide. So as I said, within the power primer of MAP 2.0, they also have the power practices, and some of these will be going through throughout this training today. In general, it's important to recognize that I'm sorry, that's not what I was trying to say. The power practice provides facilitators with resources to dive deeper into addressing power as they do this work. And this is applicable even if you aren't using the MAP process. And it outlines why the power primer outlines why each practice is important, activities that you can carry out, and suggestions for using activities throughout your process. So we'll be referencing this throughout the training. Next slide. So the first part of the power practices is process, unpacking power and privilege. So recognizing that this practice is designed to support participants, particularly those who are part of dominant cultures, to reflect on their experiences of power, privilege, and oppression as individuals, and to start to name power dynamics within their organizations. So it's going from that micro level to that macro level of understanding power and privilege. This step is pretty important when you're wanting to, anytime you plan to convene a new group, because it helps you identify and reflect on your power and your privilege, as well as the power and privilege of your organization. So we have been talking quite a bit at the beginning of this presentation. So we want to bring it back to the group together to have more of an interactive session. So for our next slide, we want to dive into one of these practices that can be found. You may have heard of this before. This can also be found in the Power Primer and MAP 2.0 handbook. You may have seen this wheel before, but this is the wheel of power and privilege. All people hold not just one of the above identities or circumstances, but varying degrees of power, privilege, or marginalization based on our identities. It's important that to note that this diagram includes many aspects of identities, but does not include them all. And some of those that it might not include are still particularly important for some communities. It's important that we individually and collectively consider and acknowledge these before we begin the work with our communities and before we begin gathering input from community members on their experiences. So we wanted to do a small activity first individually and then with small groups, and then we'll have a big group discussion about this. We want to invite you to explore your own power and privilege, share it with others, and consider how it may impact your approach to qualitative research. So we're going to start with you reviewing internally, and then we'll break out into small breakout groups. So as you can see the instructions on the board here, this is an abbreviated version of the Power Flower. Take a look at this wheel and determine the slices that apply to you along each dimension of the flower. And then take a minute, think internally, and then we'll break you out into breakup groups to reflect on these questions that you see below. So take a minute to look at where you live on this wheel, what comes up for you, and where are there parts of your identity that felt complicated to fit into this activity. So we'll give everyone a second and then we'll open breakout groups. Okay. Lori, am I cool to open the breakout groups now?
Yes, sorry, I didn't realize I was muted.
No problem. Okay. So if you're still needing to take a second to reflect internally, feel free. But I'm going to open the breakout rooms now.
And you have this handout sent to you in advance.
Yes, it should be here. And I can drop it as well.
Samantha, we had like 78 participants, I thought, and then it dropped down to 54.
I was only seeing 56.
Okay, maybe I just read something wrong. Okay. Looks like people mostly have joined. Tessie hasn't joined. There's only 2 in room 3.
Yeah, I'm moving people around.
Awesome. Only 2 in room 8. And 10. And 11. Only 1 in 13.
Yeah, I'm moving that person. Everybody should have at least one other person.
So, can the questions that we have on the next slide, can we put them in the chat? Will they see them?
Mm-hmm.
Oops, I went too far.
Hello, Simon. We are in the process of doing breakout groups for this first activity.
I'll start at the top and start popping in groups.
Okay.
Um,
Okay. Hello, everyone. Welcome back. I see some folks are still, we'll give them another second to rejoin us here. Welcome back to the main group. Thank you so much for taking the time to chat within your small groups. We want to see if anybody has any initial reactions to the activity. How might you use it? What your experience has been? If what has your experience been if you use this activity? Oh, I'm seeing a lot of
a lot of mess, I'm sure.
yeah. So I'm going to drop that in the chat. Feel free to respond in the chat. What came up for you? How might you use this activity?
Are you seeing a full page slide?
Mm-hmm.
Okay.
Oh, no, sorry. Flip them. And then you have a bunch of boxes up.
Okay. I need to stop share and reshare.
I see share in the chat. It would be beneficial to have presenters from a more inclusive group and individuals with racial discrimination lived experience at these meetings. I completely agree with that. Definitely lived experience is incredibly important for this process. Okay.
Clean screen now.
Yep, next slide, please. Or 2 slides, actually. Awesome. So now we're going to be discussing building equitable practices into your IPLAN process. So I'm going to pass it back to Lori.
Great, thank you. So excited about this portion. This is really an introduction to the rest of what we'll be talking about today. The IPLAN process components. You can see that we have everything from forming the structure, the type of committees, partnerships, coalitions, community engagement throughout the assessment and the improvement plan. All of your choosing what indicators that you're going to look at for the 7 categories and beyond of data, that analysis and how you're analyzing and looking at that data, the primary data collection that you collect either through focus groups or surveys or other listening sessions and methodologies, how you analyze that data, who you choose to be in those groups or in the survey, your selection and prioritization of your priorities, with your planning, again, analyzing those health problems and how you look at them, how deep you go in understanding the root causes and the direct and indirect contributing factors and localizing that. developing your plans, implementing your plan, and who is implementing with you, and how you just measure, track those outcomes, and track what's meaningful. So, here with us today, I'm just really pleased to be able to introduce you to our colleague, Leah Barth. Leah is the Senior Program Manager for the Alliance for Health Equity and has led multiple rounds of the CHNA process, and she can tell you a little bit more about that. And I will turn it over to Leah. Thank you so much, Leah.
Thanks, Lori, and I'm happy to be here today speaking with y'all. I know that I have worked with a couple of you in the past. For those who aren't familiar with the Alliance for Health Equity, it is a Cook County-based collaborative of hospitals, health departments, and local community-based orgs. We were formed in 2015 in an effort to do a better collaborative community health needs assessments among nonprofit hospitals in Cook County. Now, as most of you, I'm sure, know that community health needs assessments from the hospital side, it is also a federal requirement as a result of the Affordable Care Act, but theirs are done every 3 years as opposed to every 5 years like they are for health departments. However, our processes, luckily, are deeply aligned and informed with our two largest health departments, Chicago Department of Public Health and Cook County Department of Public Health. We're also aligned and work collaboratively with several of our local health departments in the suburbs as well. So that being said, I'm just going to go over a few ways in which the Alliance for Health Equity has evolved to ensure that we integrate health and racial equity into our processes for assessment and implementation. And I'll finish up with a quick case study of how we took this process from start to finish to create a equity-focused implementation program. Well, not create, support an existing one and expand it. So the first couple, and I've sort of broken this down into 4 parts, our collaborative structure, how we integrate equity into our data collection, how we do it into our reporting, and also our implementation. So as Lori mentioned, we've been doing this work for about 10 years in Cook County from a collaborative standpoint. This work did take place on an individual health department and hospital level previous to that, but the collaborative that I lead the community health needs assessment process on is currently in its 4th round of assessments. So when making the collaborative structure and decision-making process, it's important to consider how to ensure a community-driven approach in everything we do. So if we really are centered on equity and having reducing gaps and improving health outcomes for marginalized communities, communities of color, we have to ensure that our work is community driven. They are leading the process, both in data collection and then the implementation strategies we choose. Now, this process is not easy. It can be difficult to develop steering committees and decision-making processes where we're ensuring that leaders and decision makers in our processes are representative of the impacted communities. It's important to remember that this is not a static process. The Alliance for Health Equity itself, over the years, we have to continually evaluate how we are involving communities and representative leaders in our work. We also look at how are we sharing power with communities. We hold a disproportionate amount of the power as health departments, hospitals. They have the funding, they have the money, they're controlling a lot of the decisions. How are we sharing that power with communities? And it's also important to address the historical and current context in community work. We acknowledge that there are academic institutions, there are hospitals, there are health departments, and there are places in every community that have caused harm in the past. So we need to acknowledge that harm and understand how we are interacting with communities as those institutions so that we are not that we are coming from an authentic place of engagement, that we are also not continuing those harms. One classic example is helicopter public health in the past, where we've got a funded project. We go into a community, we do a program for 2 years, funding dries up, we pull out, there's no sustainability plan. That has burned bridges in some communities, and they will not work with certain institutions because of that. So thinking about those historical and current contexts in our community work are important. When it comes to data collection, I know it's really straightforward as us as public health professionals to be like, we are gathering input from historically marginalized communities. That is incredibly important. And it's important to note that in 2024, if we live in a diverse community and our assessment work and our data collection does not reflect the communities in which we live and work, that is a choice. We have to make an active choice to not be inclusive. So we have to do what we need to do to make sure that marginalized, historically marginalized communities are represented in our data collection. One thing that the Alliance has shifted to in this last round that we have been working on over the past year is compensating community-based organizations more for the work that they're helping us with. We actually took this idea from Maricopa County in Arizona. They have a very large-scale collaborative community health needs assessment process there, and they used paid partnerships with community organizations to get really good representation in their survey and focus group data of the communities that are represent their priority populations. So that's something to think about, something that we have shifted. We've started doing a couple of paid partnerships with really engaged community-based orgs to ensure that our data collection is more representative. You also need to identify geographic and demographic data gaps in data. So at the start of our process, before we start collecting any community input, any primary data, any secondary data, we look at what are the existing gaps and what can we do to fill those gaps. One example on a federal level is that we have not previously had a consistent, reliable source of federal data on the SOGI metric, so LGBTQ community. There is been some movement more recently. I know earlier this year, the Census Bureau, I believe, had a public comment period on the SOGI demographic data that they are looking to add to the American Community Survey. But how can we fill that gap with the work that we're doing to ensure that we aren't furthering harms? And then finally, ensuring data collection benefits both partners and communities. So one thing we do is that we make sure that our data is accessible to our community partners, but we also offer, as part of the exchange, you are hosting a focus group, we can create a surface area level summary of the information that we have collected for your organization if you would like to use it or that would be helpful to you. So making sure that this process you have with communities and community-based orgs is mutually beneficial. I know Lori and Samantha presented on the levels of racism. I just want to highlight again that we focus on the systemic levels of racism. Although individual level racism is important, it is not the key driver or root cause for the health inequities that we see in the US. Next slide, please. So some examples of those systemic and structural inequities I know you all recognize. We have residential segregation, unfair lending practices, school dependence on property taxes, just a number of structural issues, things like where we have check cashing institutions versus banks, environmental injustices. So understanding that racism and other forms of discrimination directly influence and lead to disparities in health outcomes. We are very explicit and clear about creating an racial equity framework for our reports. So how we report on the data, highlighting inequities that exist, and focusing on the root causes of those inequities as Lori and Samantha mentioned earlier. We also are careful to use an asset-based approach. So one thing we don't want to fall in the trap into the trap of is assuming that low-income communities, rural communities, communities of color have no strengths or benefits or people already doing the work. So it is important in a racial equity approach when in your reporting to also highlight the assets, focus on the community strengths, focus on those grassroots efforts, highlight those successful programs. And then we also have a period where we have community review of findings. We have work groups centered around different topical areas such as food access, mental health, housing, for example. And we run these findings by those work groups. We also have a number of hospitals that have community advisory groups that we partner with to run this information by. As well as other committees, and we gather their feedback on this information and if it accurately reflects what they see on the ground in their day-to-day work. And then finally, applying the racial equity lens in implementation planning. We use prioritization tools that are focused on inequities. We also emphasize those community-driven projects and supporting existing work. Sometimes that even means evaluating existing programs to see how that they can be enhanced or expanded if they're working, or how can we redirect resources if they're not. Looking at community co-design processes of our implementation strategies. And another thing that we have integrated into our implementation planning is integrating the concepts and processes associated with health impact assessment and racial equity assessment into program and policy design. Next slide, please. So this next slide just gives an example of some of the common prioritization criteria that we use when deciding on our implementation strategies. And you can see how equity is a top focus for much of it. So what is the relevance to community members? What's the depth of the inequity? What is the opportunity to apply upstream approaches? What's the cumulative impact? And then what's the alignment with other efforts? So again, even when it comes to deciding those on your implementation strategies, it's not just important to make sure that people are represented at the table. It's important to ensure that our tools are helping us make equity-focused decisions as well. Next slide, please.
Sorry, Leah. It's just not,
No worry. I think you can just hit the X on that and then.
don't know why it's not moving.
You can hit the escape button on your keyboard too. So that should work.
Thanks. Somehow it's typing what I'm saying, but it wasn't moving. There we go.
No worries. All right. So this is a quick case study to show you all how we've gone from data to action. This is an example from our last round of CHNAs, which were completed in 2022. And most of the data was collected in 2021. So you can see how we've married the secondary and primary data here. So 39% of Cook County residents live in areas of low food access. That doesn't tell us a whole lot. I mean, almost 40% is a large amount of folks who are living in areas where they don't have easy or abundant access to healthy food sources. If we look at the maps for the county, we see that a lot of that low food access is not equitably distributed throughout the county. We see that the north side and the north suburbs, as well as some of our southwest suburbs, actually have easy access to fruits and vegetables, whereas the areas on the south and west sides of our cities and suburbs are heavily impacted. So they have those lighter green colors. So this is a geographic inequity we're identifying. And then going to look at the community input we received. Some of the quotes from our focus group participants, these are all on the west and south sides of the city. Chronic health issues communities are facing come from diet and access to healthy and affordable foods. A nice grocery store would be nice, a real one, not a corner store or liquor store, fresh market to be able to eat healthy. So focus group participants are giving us context to the secondary data that we have. And then we also do a community input survey, and it showed that 14% of survey respondents identified access to healthy food as being needed to support improvement in community health. So if we go to the next slide, you'll see the implementation, one of the implementation strategies that were used to address this issue. So food security and food access, as I mentioned, were identified as health priorities with a focus on Black and Brown communities on the west side of Chicago. If you were to look at our reports from our previous cycle, you'd also see that we highlight that in Chicago, west and south sides of the suburbs and city have communities that are predominantly Black and Brown. They also have high immigrant populations. So that became, and that geographic disparity again that we saw. So this program is centered on the west side of Chicago and Black and Brown communities. It's the expansion of the Food is Medicine Veggie RX program. Veggie RX, for those of you who are unfamiliar, is a cooperative produce prescription program. It allows community clinical partners to prescribe fresh produce boxes and cooking classes and other nutritional education support to patients with diet-related diseases who are also food insecure. And then it's a warm handoff, like patients get produce boxes that day in most cases, and they are connected directly into additional programs. It has grown tremendously since this program started in 2016. It has distribution sites across the west side of Chicago, including some of our communities that have highest inequities, both in chronic disease, chronic diet-related diseases, as well as low food access. And in 2022, more than 17,000 Veggie RX bags were distributed to more than 2,000 participants. And we've also tied this into other strategies, such as the support and development of urban agriculture. So looking at local farms are providing the culturally relevant produce in the bags. It's being connected with cooking classes. It's also being connected with greater strategies like procurement at anchor institutions such as hospitals and schools. So we have this workforce economic development's been tied into this Veggie RX, these food access strategies. So you're seeing how we're taking the data with the equity focus and creating an equity focus implementation plan. So that was just a quick taste of sort of the, so to speak, of the work that we're doing at the Alliance for Health Equity. And again, this has been an evolving process over 10 years. We're constantly seeking ways that we can improve our efforts in this area. And with that, I'm not sure if we have time for questions, but if not, Lori and Samantha definitely know where I am.
Thanks so much, Leah. And yes, we will definitely field questions and get them to you. I know you can't stay on for the whole meeting, but let's see if we do have one in the chat now. Who's paying for the produce and the Veggie RX, and how do people get to the distribution sites?
Yeah, so I'm not the lead on the Veggie RX program, so I will answer to the best of my ability. But there is a links in the chat for folks who have linked it to the main site on it. It is a blended funding model. There is reimbursement options. There are reimbursement options both through healthcare and like managed care sort of processes. There's also grant funding, and also the institutions are also supporting part of the funding for the programs.
Thanks,
I'm
Leah.
not, yeah, and I'm not sure what the prerequisites are for the Food is Medicine. Do you mean to implement a Food is Medicine program, or for a patient to be referred to it?
I think we'll have to table those questions about Veggie RX since we have so much to get to related
Yeah,
to
absolutely. And I can definitely, if folks have additional specific questions, I'm happy to refer my colleague who leads up that work. And also, Jess and Lori know how to get a hold of me, and you're more than welcome to share my contact information. So thanks, everyone.
Thank you so much, Leah. Really appreciate your time today. I do not know what is going on with my screen sharing, but we're going to pick right up. Samantha had introduced the power practices in the last section, and she talked about process, unpacking power and privilege. And that was just, you just got a sample of being able to explore that and thinking about how you can use that exercise with other groups. And we're going to move on and look at other power practices and some tools that you can use. So the first one, the next one is form, and form is about building a container for the work that you do together. And I think this is something that we can all really start with. It's a great way to think about building equity into our work. And if we think about this as the practices and norms that create a space for individuals where they can be together and work together in a way that provides opportunities for everybody to contribute, the way that we create and cultivate that space for it to be welcoming and inviting, whether that there's a lot of variety of different ways of doing that, but we want to make sure that we are including uh, uh, thinking about using pronouns. We're thinking about the identities that people bring to the table. We're thinking about the way that we introduce ourselves and we introduce each other, the group agreements that we set up, and all of that. But we want to be explicit in what we're doing and what we're trying to accomplish, how we're learning and unlearning some things, how we're practicing different ways of being together. And so all of those things are important. Um, Looking at some of the recommendations here, real quickly, um, this container really provides the context for the work grounded in assumptions for agreements for how the work gets done and how we work together. The first step in really building this container is identifying who's going to be in the space and who's going to be there together, thinking about that initial group, the groups that you bring together, whether this is the partnership, the steering committee, a subcommittee, a focus group, whatever it is, but thinking about what do we need to do? What do we need to put in place so that people feel comfortable, people are able to contribute, people are able to talk, and even who's facilitating the meeting. And I think today we had a great suggestion in the chat about ensuring that we have people with lived experience who are, part of the training team that's on delivering the content, how important that is. The same with our group and our meeting facilitators as well. So here's just a few best practices, some of the ideas and ways in which we can create that container. And we're going to share a couple more as we go throughout these slides. One of them that we'll look at is looking at group agreements and how we set up group agreements, but it's also how we set up that physical space. Are we setting it up so people are talking to one another as opposed to looking at backs of heads, or there's a head of a table? What kind of messages are we sending with the way we set up the room? Do we have welcoming music playing? Are we sharing food? Are we bringing in things that people can really gather around and connect over, but also be able to celebrate differences? So thinking about some of those types of things as we're thinking about building that container for our work together and for these types of discussions. Another practice is reintegrating the head and the heart. And so when we think about reintegrating the head and the heart, it's really about allowing us to feel what we need to feel and be able to express what we need to express, but also be able to do the work. So we want to be able to recognize what people are going through. We want to be able to have opportunities for people to pause and take care of themselves, to identify if something is emotional, when they're feeling certain things. We want to be able to pause and reflect on that, but also allow people to have the emotional responses that are natural when we have some of the types of conversations that we are talking about. And other related to heart-centered practices, just continuing on, they're important in all of our work and all of our relationships we can and should incorporate these practices into any collective spaces where we're learning and working together, whether it's teams or committees or organizations. We want to try to take time to understand the access needs to our group and always offer offer any practices voluntary that people have a right to pass. Something we should have made clear on the last activity as well. But allowing people to participate at the level that they feel comfortable participating. And that's just an important piece to remember, whether we're doing an icebreaker or whatever it may be, that we give people that opportunity to have that autonomy over what they want to do or don't want to do, what they're comfortable with. Um, Racism and other systems of oppression are really forms of trauma, and we want to keep that in mind, that trauma lives in the body and requires us to recognize and feel that in order to heal from its impacts. So in a traditional or typical professional setting where we're trained to just be intellectual with one another or analytical, we tend to not make space for feelings or physical feelings or any type of trauma. And in this type of work, if we do this and we don't allow for that, we're not able to engage in long-term commitment to racial justice. We need to be able to allow for people to feel what they feel, recognize that that is likely a part of what's going to happen. It's a big part of really integrating this practice of head and heart and being able to integrate the two into our work. So as for some people, the body is really a source of trauma as they experience that. And we want to let people know that we understand that, and we want to be able to communicate that as we're moving in. So there are a lot of good trainings on trauma-informed practices and care and thinking about what needs to be done as we're setting up meetings like this. And that's why bringing in trained, experienced facilitators, if you're having discussions that are going to be around racism, are really important. But at the same time, if we're talking about health and we're talking about health issues, racism is going to come up as an underlying root cause. And these specific examples of how it's integrated into our systems are going to surface. And so we need to be mindful of that and be prepared for those discussions and for people to take the time that they need to take care of themselves and us to take care of each other. Part of that is building a brave space, and you see some community agreements here on the screen that are different than some of the agreements that we set forth when we were talking about the training. So I invite you to take a look at these. They're really can be very helpful and just think a new way of thinking about some of the community agreements. And it's good to share some of these and then ask the group, which ones really resonate with you, which ones are important, what might we use or add to our group agreement. So this can be a nice tool for you to use. Another tool that's important to have is a shared or common vocabulary. And so that when we share a word or we use a word, we're all defining it in the same way. So there are a lot of different glossaries or tools out here. We've shared one race equity tools glossary here for you to take a look at some of these terms or see what you might want to look up or what terms you may want to use when you're having discussions with your groups. And then the next sort of power practice that we're going to talk about is study. And this is really related to learning about your community's history, and even those communities that we say, well, we don't have much variation in race and ethnicity in this community. It's really important to understand how your community came to be, to understand the history of the land, and just the community and the region overall. So to address health inequities in your area, you need to know how and why those inequities came to be. We also need to think about that it's not always only race. All those other intersections that we talked about are also important, and we want to understand how inequities are perpetuated in the community and where they came from. So learning about the history of the land and the communities in your area is really critical in understanding what to do differently, how to change current conditions, and how to repair past harms. So when we do this, we're continually making space for community members to share their stories and learn more about the community's history. And it's a nice way to be able to start from everybody having the same understanding of how things came to be. So a guiding question for this work is how and why did our city, our town, our region, our area come to be like it is? And you can dig in deeper. There's different ways you can do this by meeting with local librarians or historians or seniors in the community, paying attention to the histories of Indigenous and Black communities and others before the city or town incorporated, and over time. Look at and think about national or state policies and practices that impacted who came to live in your area, and sort of develop a community history timeline before you begin the chaw and chip process. It's a great introduction to understanding your community, and when you do that overview of the demographics of who lives in your community now, being able to provide that historical context. So we've got a couple quick poll questions here that Samantha will run. The first one is, do you have a strong understanding of your community's history? And again, these are anonymous, so don't worry about us knowing who's answering what. So yes or no on this poll question. I had just a few of you answer right now. And the second question, you'll scroll down on that poll that came up, is what's the best way to learn more about the history of your community? Thinking about your community, where would you go? Who might you talk to learn more about the history of your community? And let's see, we have over 50 people on the call, and we've got about 20 some answering. 20. Keep those answers coming in. More people know about their communities than not, but it is a pretty good split there, to really be able to think about that in-depth history, whether or not you know that or not. Well, let's hear what some of those ideas are for number 2. What are some of the ways that people are recommending to learn about the history, Samantha?
Sorry, one second. I was looking for the unmute button there. So what we're hearing from folks, the best way I've learned about one town in our county is listening to a presentation on the history of immigration from the local museum. That's really cool. Asking older community members and checking local libraries. I love that. You learn a lot from elders in your community. Communicating with other agencies and libraries, learning through grandparents and parents who have also lived in this community since birth. A lot of libraries, historical societies, community members attending community functions, the county recorder's office, elders again. The various committees, Chamber of Commerce, County Museum. I love everyone saying the library. I love a library. I lived in the library most of my childhood. Historical societies. Be a part of the community or have experience living with the same communities we serve. We have a lot of staff that are lifelong residents. Looking at archives, talking with Indigenous folks. Church leaders are a good resource. They're often folks who have lived in the community for many years. Path health administrators.
We've got a couple in the chat too. The city hall, library again, school districts, and by joining community organizations, you can definitely learn a lot. And many of them have historians that can share information as well. Well, thanks for all those great ideas. We're gonna just keep moving along. Thank you, Samantha. The fourth power practice here that's listed is cultivating relationships with communities and partners. And so for this particular practice, we're really talking about two types of organizations. We're familiar with community-based organizations, but community power building organizations are groups that build power together with community members to address social determinants of health, like housing, economic security, immigration, or the criminal and legal system. So these groups might be working to change policies and laws, changing government agencies' roles, and shaping people's daily lives. They might be working to change narratives and public discourse on important issues and populations, or even working on changing the distribution of power. So these are groups that really understand what's going on in the community and are great to connect with. In smaller communities, you might think, well, who are our community power building organizations, or who might those be? So think about who serves your area, who serves your region, that has a special interest topic, that really works at the grassroots level, and our community, could be community power building organizations. So in the chat, what are some unique or different community-based organizations or community power building organizations that you work with? Put a couple ideas in the chat. So if there's a CBO in your area that you work with, or a community power building organization in your area that you work with, list those in the chat and we'll take a look at those. Let's see.
Click one more time on the slides.
Click one more time on the slide.
Yeah,
Oh, I'm sorry. There we go. Anybody have any thoughts on in the community CBOs or community power building organizations? I'm going to just keep moving us along, but please add those to the chat. So we do want to look at the difference between community engagement and community power, because we are definitely exploring power practices, and we'll look at the spectrum of community engagement. But both community engagement and community power center on those affected by a system's historical and current patterns of exclusion and marginalization. Community power is driven by a base of people whose presence and voice are sustained and maintained over time, and who exercise their power on a range of issues. And that could be voting rights, affordable housing, transit, food, etc. So thinking about that, and then we'll take a look at the power sharing with partners and community internally and externally, some additional terms here. So there's community engagement, there's power sharing, there's community power building, there's co-governance. But all of these practices focus on power and building power within the community, and especially with those most impacted by inequities. So we're going to take a look at a tool that we use often with communities that we're working with, the spectrum of community engagement. And I'm going to flip over to another slide really quickly. You might see it as the slide that's on the left side here. This is the same information that is in this slide. We just put it in a different visual to make it a little bit easier to read. And when you see the header here, like ignore, inform, consult, involve, collaborate, or defer to, that's really the perception and can be the impact on the community. So in this phase where we are not allowing the community to be part of decision making, and the way things happen are through closed door meetings, etc., we're really ignoring. That's the impact on the community, is ignoring. Inform is the next level or phase across the spectrum, where we're providing information, and we're providing information to the community. So we're giving the community information. It's what we think they should know, fact sheets, other promotions. You think of like certain times public health was giving out information only in COVID and maybe not seeking information back. That's a time where it may or may not have been appropriate to be at that level, because there's different times where many of these levels, particularly on the right side of the spectrum, are appropriate to be in. Um, Consult is where we're gathering input and information from the community. So when we're gathering information through focus groups or surveys and things like that, that's when we are really consulting with the community. But sometimes the impact can feel like tokenism, that we're not really invested in using that information that we are collecting. So we really need to be careful about that. And if we're engaging people and we're asking people, we're using that information and we're letting them know how we're using that information. Involve is next, ensuring that needs and assets are woven throughout the process. And so this could be much more ongoing rather than at one point in time where we're sharing information or soliciting information, but it's woven throughout. It's the way that we're doing things, that we have opportunities for involvement from the community throughout. Collaborate, where the community plays a leadership role. They co-design, they co-implement solutions. And then finally, defer to is ownership. It's, that's the outcome or the impact, is that equity is being achieved through community-driven decision-making. So thinking about this spectrum, where do you, I'm gonna jump ahead, Samantha. Where do you think that you are across the spectrum of community engagement most of the time with your IPLAN process? And if you're not in an IPLAN process, with the way your organization works with community. So we're probably in all of these at some point, or at least many of these, but where do you work most of the time with community? And remember, collaborate is community plays a leadership role. They're co-designing, co-implementing solutions. We got some answers coming in here. If you have diverted your attention to something else, you can jump back on and answer the poll. That'd be great.
And as a reminder, this is anonymous responses, so feel free to answer however you'd like, to the truth of the work that you're doing.
Well, it looks like it's fantastic. We have a lot of people at the collaborate and involve phase, consulting and informing. Luckily, have no one at the ignore stage for most of their work. So that's great. We'll just end that.
And there's a good
Yeah.
comment in the chat. I think a large barrier here is that we are required to do this work, but if we would like to compensate residents slash community members as consultants, funding can be a barrier.
Absolutely. Absolutely. And what we have found is that's where it really comes in handy to partner with other organizations to do this, because they can provide funding to help support that data collection. Also, we have found that these are things that they have lower barriers on being able to fund or pay. So hospitals may be able to contribute, or United Way or other organizations, to really being able to pay people for their time. But yeah, coming up with the budget for those and deciding, making some decisions around what you're going to fund or what you aren't going to fund in as part of your IPLAN, and the overall process being unfunded, mandate that you have to do, is definitely a challenge. And then co-designers, someone said, great, Becky. There are different services in a department that are, by the nature of the work, required to engage the community in very different ways. Regulatory agencies sometimes must operate on the left-hand side of the chart. Exactly. Thank you, Erin, for pointing that out. Okay, so ways that you can use this spectrum that I think are important, and we really use it with community groups. So when we're working with, the partnership or the steering committee for your IPLAN or whatever you call it, we're really looking at that spectrum and saying, where can we do more? How can we do more to get to the right side of the spectrum? We look at it for a couple things to really be able to name and acknowledge where there's marginalization, where we're breaking down, and so that we can break down existing barriers to participation. Why aren't we getting participation instead of just automatically defaulting to marginalizing communities? To be able to assert a clear vision of where we want to be on that spectrum and that we're prioritizing inclusion, to articulate that this is a developmental process and that we're not going to start on defer to. We're, not only do we need to do this really gradually and in phases, we need to know what we're doing and how we're doing it. And we need to prepare the community for participation as well. Providing the environment so that it is a productive experience for them, that it's a good experience so that they want to participate again. So we really have to be ready for it as opposed to just jumping to that end. So investing in the capacity to be able to have that participation at the level and break down the barriers that cause people to not want to participate. And then to be able to look back meaningfully at our participation efforts to see where they were and how we could have improved. Those are important ways that you can use the spectrum. So just another quick chat question. Why is community engagement important in advancing racial and health equity? So why is community engagement important in advancing racial and health equity? What are your thoughts here? Anybody have thoughts on this?
Yeah, I would say because any work that we're doing for the community should involve the community.
Thank you so much. Absolutely. To get a better understanding of the population we serve, so you can hear what hurdles they're facing. Absolutely. So much more meaningful. And also, they have the best, everyone has the best understanding of their own experience and has ideas for solutions. The more representation we have, oops, lost that one. We have from multiple groups, the better representation our data and decisions are of the actual populations. To identify gaps in community resources can tell us more than quantitative data alone can. We hear a lot of the why and we really understand better. Too often we assume the issue, but there may be something that we don't even see from the outside. Great. And by fostering trust and mutual respect. Absolutely. Thank you for those great answers. So we are moving into the last section of the training. We're a few minutes behind. So I think we're going to have to skip a breakout group, but we will still watch this quick video. So in this next phase, implementing health and racial equity practices in the community health improvement plan, we're really going to be talking about policy systems and environmental change strategies in a very brief way. We can't get into it in depth. It can be a whole training. But we're going to start by just watching a quick little 4-minute video on unpacking structural racism. And we were going to go in breakout groups and talk about the video, but instead I want you to think about in the chat how you might use this video or how this video could be helpful as you're talking about systemic racism, structural racism in your communities, and how that could lead to better planning. So I will advance to a video here and let me know if this works, Samantha.
Kamal is a boy who lives in a poor neighborhood. He has a friend named Kevin who lives in a wealthy neighborhood. All of Jamal's neighbors are African American, and all of Kevin's neighbors are white. Because Jamal's school district is mostly funded by property taxes, his school is not very well funded. His classrooms are overcrowded, his teachers are underpaid, and he doesn't have access to high-quality tutors or extracurricular activities. Kevin's school district is also funded by property taxes, so his school is very well funded. His classrooms are never crowded, his teachers are very well paid, and he has access to high-quality tutors and lots of extracurricular activities. Kevin and Jamal live only a few streets away from each other. So how come they're growing up in such different worlds with such different opportunities for success? The answer has to do with America's history of systemic racism. To understand it better, let's look at what life was like for Kevin and Jamal's grandparents. Decades after the Civil War, many government agencies started to draw maps dividing cities into sections that were either desirable or undesirable for investment. This practice was called redlining, and it usually blocked off entire Black neighborhoods from access to private and public investment. Banks and insurance companies used these maps for decades to deny Black people loans and other services based purely on race. Historically speaking, owning a home and getting a college education is the easiest way for an American family to build wealth. But when Jamal's grandparents wanted to buy a house, the banks refused because they lived in a neighborhood that was redlined. So Jamal's grandparents were not able to buy a home, and because colleges could prevent them from attending through legal segregation, their options for higher education were really scarce. Kevin's grandparents, on the other hand, got a low-interest loan to buy their first house and got accepted into a handful of top universities, which traditionally only accepted white students. This opened up a wealth of opportunities that they were able to pass on to their kids and grandkids. Even as late as the 1980s, an investigation into the Atlanta real estate market showed that banks were more willing to lend to low-income white families than to middle or upper-income African-American families. As a result, today, for every $100 of wealth held by a white family, Black families have $5.04. A 2017 study confirms that redlining is still affecting home values in major cities like Chicago today. This explains how Kevin and Jamal inherited vastly different circumstances. Unfortunately, the story doesn't end there. A big part of systemic racism is implicit bias. These are prejudices in society that people are not aware that they have. Let's go back to Kevin and Jamal. Against all odds, Jamal manages to be the only student from his high school to get accepted into a great university, the same one that Kevin and his high school friends are attending. But after Kevin and Jamal both graduate, Jamal notices that his resume isn't drawing as much interest as Kevin's, even though they graduated from the same program with the exact same GPA. Unfortunately for Jamal, studies show that resumes with white-sounding names get twice as many callbacks as identical resumes with black-sounding names. Implicit bias is one of the reasons why the Black unemployment rate is twice the rate of white unemployment, even among college graduates today. You can see evidence of systemic racism in every area of life. The disparities in family wealth, incarceration rates, political representation, and education are all examples of systemic racism. Unfortunately, the biggest challenge with systemic racism is that there's no single person or entity responsible for it, which makes it very hard to solve. So what can you do? The first thing you can do is work towards becoming more aware of your own implicit biases. What are some prejudices that you might hold that you're not aware of? Second, let's acknowledge that the consequences of slavery and Jim Crow laws are still affecting access to opportunity today. As a result, we should support systemic changes that create more equal opportunities for everyone. Increasing public school funding and making it independent from property taxes would be a great start so that poor and wealthy districts can receive equal access to resources. Systemic problems require systemic solutions. Luckily, we're all part of the system, which means that we all have a role to play in making it better. Peace.
Great. So, told you it was a quick one. We won't do this in a small group because we're gonna just try to keep moving, but what's your reaction to the video? You can unmute your line or type in the chat. And how might you use the video? We don't have to do all the questions on the screen here, but how might you use this video in your community? Could you see it being helpful with people understanding structural racism?
Hey, Lori, I could actually see using this video in our steering committee meeting, as I'm preparing now for like what the agenda will look like. We're definitely going to dedicate a substantial amount of time for that first meeting to community power and understanding power sharing and power shifting, racism, systemic racism. And so there was a video that I had in mind already that we'll be sharing, but I do like this, and I think we can incorporate it into the agenda.
Great, thanks, Dolores.
Yep, no problem.
Other comments?
The same here. I loved the video, and it's nothing like a short video that kind of sums it up, quickly and easily. So I can see using it in different committees and trainings, just trainings for staff, but then I'll also bringing it into the community as well.
Thank you. Natalie, is it?
Yes.
Thanks so much. Anybody else? It definitely packed a lot of information into 4 minutes. So that's what I like the best about it. And it's a good video to just spur conversation and even to use some of these questions to think about your own community and how is our community designed and how are some of those structural barriers impacting the members of our community. Great. Well, I will keep on moving here. Let's see. Again, it's just going fast. Okay. So as you saw in the video, and as we're thinking about, and we're here, and we heard from Leah, when we're thinking about the impacts, the underlying root causes of structural racism, we really think about transformational change. We think about policy systems and environmental change. And so as we're thinking about strategies for transformational change, there's 3 main core things that we're looking at. One is making sure that we have this shared understanding of the system. So I think a video like that helps just like break the ice, and so to speak, in terms of being able to say, okay, this is what we're talking about, really getting back to the underlying impacts of systemic racism. So we want to develop that shared understanding around how power imbalances, racism, and other forms of oppression define the structures and the systems that we have in place. We want that shared understanding. And we know that that dialogue can be challenging sometimes to have, and some people are going to see things differently, but it also tells us how we need to make sure that we have people with lived experience who can really share those experiences to make sure that we are developing that shared understanding. And so those stories can really be important. So even though we didn't know Jamal, we were able to understand through the storytelling of the difference between Jamal and Kevin's upbringing and history, how that came to be. We also want to deepen relationships so that we can disrupt patterns that are occurring. So developing those relationships that are really going to be necessary at the interpersonal, the team, the organizational, and the community level. So we need to be able to identify who those folks are, who has the power, and develop those relationships, both people who can be good messengers, and also understanding who holds the power. So there are different levels of power. There's invisible power, there's visible power, all of that. We want to think about along those different ranges of power, who holds that and who are the relationships that we need to be building. And I'm working with some groups right now where, there's different sort of strategies where people think, oh, well, I've tried to reach out and invite them to a meeting. But a lot of times we don't just come to a meeting when we get a cold invite from, someone we don't know. So building those relationships more one-on-one and through other people are really the way that we get some familiarity and we start to trust to be able to say, okay, I might come to a meeting that you're offering because so-and-so knows you, or so-and-so said that, I should really go to a meeting with you, or I met you out at such and such event and we had, a brief conversation. And so then when I get something from you, I'm more apt to go. So it's really important to think about that this relationship building doesn't just happen behind a keyboard. And we sometimes have to pick up the phone, and a lot of times we just have to go out into the community and meet people. And then the last strategy for transformational change is establish equitable change processes. So establishing change processes that embody a model of sharing power, and that's really what these next pieces are really focusing on in the power practices. So I want to mention the water of systems change, and this is a well-known parable that helps explain this model that we're going to show you in the next slide, the water of systems change. So based on this, complex problems have a host of visible and not so visible constraints, including government policies, societal norms and goals, market forces, incentives, power imbalances, knowledge gaps, embedded social narratives, and many, many more. These surrounding conditions are all the water. And like I said, some of them are visible and many are not so visible that we just don't see them. So the first step in seeing the water is to illuminate the systemic forces at play. And again, that's why I think the video can be a good spur to start that conversation. And to illuminate that, we need to engage all of the actors that touch the issue that we seek to address or change. And then we have to go further to explore the relationship among these actors, the distribution of power, the institutional norms and constraints within which they operate, the attitudes and the assumptions, the mental models that influence decisions. And these are all the conditions that significantly impede or enable social change. So in this parable, there's a fish is swimming along one day when another fish comes up and says, "Hey, how's the water?" And the first fish just stares blankly back at the second fish and says, "What's water?" So you're in it so much and you can't even see it. You don't even know. It's just there. And so we want to identify and name what that water is and what's going on in that water. So for the water of systems change model, there are 6 conditions of systems change. And so this is what everything is made up of systems, right? Everything that we touch, everything we interact with all day long, we interact with a million different systems. So they're made up of policies. This is big P and little p policy, practices in the way that things are done and conducted, procedures, all of those resource flows, the way money goes in and out, the people, the knowledge, the information, assets, all of those things that go in and out and back and forth, the relationships and connections, the power dynamics, and the mental models. And if you look at these 6 conditions of systems change, they fall into 3 categories: structural change, relational change, and transformative change. And so the transformative change is mental models, those habits and thoughts, those deeply held beliefs and assumptions that are really oftentimes taken for granted, the ways of operating that influence how we think, what we do, and how we talk. So making change at that level. The things at the relational level are the power dynamics, the relationships and the connections. So who has the power? Who's at the table? What are those connections? What are those relationships that are built? Who knows who? All of those types of things. And then the structural change are the policy practices and the way resources flow. So when we're thinking about this and we're thinking about systems change, it's very complex, but you can break it down into these different areas and you understand how important the type of conversations that we need to have, and how starting with ourselves and being able to bridge that out to impact mental models, to build relationships, all of those things, so that we can make impacts and differences at the policy, practice, and resource flow level, so we can really make systems change happen. On this next slide here, as we're closing out the last two steps, we have strategize and act in the power practices. And in this one, we're looking at implementing, amplifying, and investing in community identified priorities and solutions. So we are, again, looking at that relationship piece of who is part of our community power ecosystem that can help identify who can help apply action steps and help us move this work forward. Those of you working in a local health department, you may need an inside strategy to move your public institution to forward to support and advocate for certain actions. So who do you need to be able to organize your institution or building a network to build champions to be able to address a certain systems change issue? Looking at doing a power map and developing a power map, especially internally, on who those champions are and where you have and need champions, and doing an external power map, a landscape analysis and power mapping to find out where does the power lie and where do you need to build relationships and influence change. So looking at this next model or framework here, you can see these different areas. So we invest, we amplify first as you identify strategic priorities, reflect on the supporting narratives that you want to lift up and be able to amplify that and amplify those voices. And storytelling and people with lived experience can be so impactful in that, as well as data and quantitative data. Investing, sustaining the work and supporting community power building in the long term, and identifying sustainable resources to do that, applying and enforcing that. And then finally, the last step, and I know I'm moving fast because we are near the end of our time, is reflecting on the process, the outcomes, accountability, and sustainability. So you're evaluating your impact, you're evaluating what you're doing throughout another power practice, because when we're evaluating, we're not just looking at our numbers, but we're asking the people that it matters to if it made any difference to them. So there's several things to think about, and this really introduces what's coming up in our next training, which is next week at the same time, on quality improvement in the community health improvement planning portion of the process. And we'll talk a little bit about process and outcome indicators during that training. So with that, I'm going to turn it over to Samantha, and she's going to take us into our training assessment.
Thank you so much. Thank you all. First, we want to say if you have any questions, feel free to drop them in the chat. We'll send a follow-up email with responses to questions, whether we're answering those or we get those questions answered from other experts or partners or Leah, whatever you're looking for. So feel free to drop that in the chat. Next slide. So if everyone could take a couple minutes, I'm dropping the assessment link in the chat. Take the last few minutes here to respond to this training needs assessment. Let us know what you're hoping to get out of the training series next year, what topics that are most relevant to you. We would like your input to better prioritize your health department's needs, and what topics are important pertaining to the community health assessment, community health improvement plan, and other aspects of the IPLAN through implementation and monitoring as well. So take a few minutes to respond to that. And just for time's sake, I'll also drop 2 other links in the chat. One is for today's evaluation. We want to hear your feedback on this training and our future training, so we can always continue to improve upon our trainings. And we also included a link to the full webinar series. We have one session left we have one training session left this year, and that is for quality improvement training. And that is next week on the 21st. And we have a TA session that'll be focused on a Q&A with IDPH data stewards. If you're interested in participating in that, that'll be December 4th. So take a second to feel free to save these links, open up the assessment link, to start responding, and we will also send this out in our follow-up emails. Thank you all for joining us today, for participating. We loved hearing from everybody, from your perspectives and the work that you're doing. Appreciate you taking the time out of your day today, and have a great rest of your day.
For those of you who are taking the survey, the training assessment, that is the needs assessment for planning for next year. We are also going to be sending this out to all local health department administrators and anyone who's ever registered for any of the trainings in this series. So if you receive an email on it and you've already completed it now, you do not need to take it again. We're hoping to save you some time by taking it right now at the tail end of this training, and so you don't forget another time. But if you have to run to another meeting or something like that and can't do it right now, we will be sending you an email with that link in it. But please do take the survey. We're going to be gathering data for a week. And I just want to thank you all so much for your participation. We'll be sending out a link to you with the training slides and the recording of the training. And you will also see that there are several resources listed for additional resources. So I highly encourage you to dig in. I'm sure you also have many resources that you're aware of, and we'd love for you to share them with us if you do have other resources. So with that, I think we can stop the recording, and I'll just make sure everybody got this link before we